Well, we're getting close to the end, so we just have the final speaker, which is Claudio Saccavini, and Claudio is the technical manager of Arsenàl.IT in the Veneto region. Oh, he's right there, just saying, where's he at? So Claudio will be talking a little bit about renewing health from evidences to policies for us. Thank you.
Okay. Thank you. The microphone does work?
Yeah.
Okay. Oh, first of all, thank you for this opportunity to talking about the results, the preliminary results of renewing health. My presentation is starting from the evidence of the renewing health, moving to the policy, because in the next 3 months in my region, the decision maker has to decide if they move to deploy of these results in real-life system, or they stop these services. And it's very important to understand what is the right key points for the decision maker to decide if this is a good solution for some chronic disease management. This is the congestive heart failure. I'm talking about cluster 7 results so in Veneto region, that is about the congestive heart failure. And this is the epidemiology, but I think it's the same also in the other region. It's very interesting looking to the result of the Norrbotten pilot, the differences of these 2 types of sample size, because you have a 65 years old as mean age. In the case of Veneto region, there are 78 years old mean age. You have 80% of your sample size that are familiar to the use of the PC. In Veneto region, only the 20% of the people are familiar to the use of the PC. This is incredible social differences and bias in the results, of course, but the pathology is the same, and this is very important. And this is the schema of our implementation. Is based on a telecare center that collects the data from the devices at the home of the patient and then moves the alarms to the specialist or to the general practitioner, or in some cases, because the services is an integration between telecare and tele-home monitoring, to the social workers, of course. This is the very key point of the description of the services, because the previous slide is a typical schema of the workflow from the technical point of view and the organizational point of view, but it's not sufficient for the decision maker to understand completely the services. We need another type of description. This is the business model canvas that describes to the decision maker different parts. You see that in the center of this canvas, you see the value proposition, and it's very important to focus on this value proposition also for the patient, for the caregiver, and for the local health authorities. Then, in the bottom part, you have the cost and the revenue, because it's very important if this business model is sustainable, if we have the possibility to deploy it on large scale, and which is the investment to this deployment. Then you have the key partners, key activities, and key resources. You see some parts of the patient, and not only the patient, and as key resources, it's very important to focus on organizational model. Then on the right part, you have the customer relationship, the channels, the channel on which you promote your services. It's very important to find the right channel. In our case, we decide that the general practitioner are the right channel of this type of business model. And then the customer segment is very important. For the revenue, it's very important to understand that for our mutual sustainability NHS, we cannot have non-cashable savings, of course. And from this business model, we find the assessment of the service, talking in 3 different directions. The first is the feasibility. The other one is the desirability of the services from the social point of view and the policy maker point of view. And the last is the viability of the services. This is a randomized control trial. I think that Panos has completely understand the difficulties that we have to perform a randomized control trial in real-life laboratory, and this is an incredible difficulty. And so we have this is the inclusion criteria and the exclusion criteria. You see that the patient have a discharge from the hospital after acute heart failure episode. This is very important. This is the primary outcome. It's a combined endpoint of all causes of mortality and number of hospitalization for heart failure, of course. And as secondary outcome, you can see also the health-related quality of life and XF56 and other outcome that I'll show you later. This is the preliminary results. After 9 months, we continue the follow-up, and in the next month, we have the final results of 12 months. You can see that the primary outcome has a good decrease, and this decrease has a statistical significance, and so we have this first preliminary result. As secondary outcome, we have a reduction in the number of hospitalization, but with no significant statistical. We have a reduction of number of hospitalization for congestive heart failure, and this is significant statistically. And we have also a reduction of the percent of the patient hospitalization. Then we have a reduction of the number of visits to the emergency department with no significant statistically. We have a reduction of number of specialistic visits for congestive heart failure, and this is with the statistical significance. And we have also a reduction of the number of specialist visits and procedures for congestive heart failure. This is the clinical outcome that we have after 9 months of follow-up. You can see here the trend of the outcomes during the period of follow-up. We measure the outcome after 3 months, 6 months, and 9 months. You see that the great benefit is in the first 3 months. So this is one result. It seems that it's very useful to have a short-term home monitoring and not a long-term home monitoring. But you find that also for a long-term monitoring, you have a good results. All this has a significant, statistically significant. From the economical point of view, we have to use the ICER as a method to assess the outcomes. But we have the intervention that is cheaper and more effective because we have the results in primary outcome, and so we don't calculate the ICER because it's not significant in this case. So we move to calculating the budget impact analysis. This is the budget impact analysis calculated on our epidemiological data. We're talking about that we have 20,000 patients that can enroll in this type of telehome monitoring. And you can see that for a 3.54 euros for telemonitoring cost for working day, you can see that at the end we have a ROI of 153%. This is a good result. That it seems that the service is economically sustainability. From the organizational point of view, we measure all the time that this service consumes to clinical staff and to the physician and nurse, to the patient, and also to the e-health center. You can see that in green, the new task that we introduce with the service compared with the usual care service. And calculating all the time that clinicians spend in this system, we can find that for one full-time equivalent, can follow about 1,200 patients by year with tele-home monitoring. This is very important because it gives an idea to the decision maker of the change in the staff, because one of the results of this trial is that the doctor, I saw you after, say that it's an increased amount of work. Yes, because they follow the patient in tele-home monitoring, but the time that they save, for example, for an ambulatory visit, is waste, because other patient goes to the patient that to the slot, to the free slot in ambulatory scheduling. From the regulatory perspective, we have analyzed the European directive, the national directive, of course, and the compliance rule for certification and the operative protocol. We have a lot of rules. It seems that we don't need other rules, but it's very important to define the local operative protocols. This is very difficult because sometimes it's very difficult to find the inclusion criteria of the exclusion criteria in these tele-home monitoring services, because doctor enroll the patient not every time using clinical criteria or organizational criteria, but sometimes using pragmatical criteria. It seems that in this case, tele-home monitoring is useful for the patient because, for example, the patient lies very far from the hospital. But it's very important to fix the rule of the games, fixing the operative protocol at local level. From the patient perception, we have the same methodology of the Norbotten trial and the other trial of Renewing Health, and we have the same results in all the trials, it seems. And it seems that we have the same results of the Whole System Demonstrator project of UK. It seems that there are no differences in the patient perception. And so you can see that the enhanced care is very high. You can see that in the scale, on the top, you have the maximum agreement of the patient about the question and the max disagreement of the patient. So in this case, patients accept the service and they feel less concerned and actively involved. It seems that the patient very love this service. I use the term love because if you go to our website, you find the patient history. There are some video also in English. And so you find that for the patient, it's very useful to have a tele-home monitoring. It's very increase the safety of their condition. From other point of view of the perception, we have the same result for privacy, and especially for privacy, and for kitten substitution. It's very important because it seems that patients are concerned about privacy or care personal use and don't feel discomfort. The service isn't perceived as a complete substitution to user care. I don't know if this is the right photo, especially about privacy, because it's clear that these patients are particularly involved in these services. They are particularly motivated to as this service. And so in this case, it seems that privacy is not a high danger perception from them. Another important point is the impact on the caregivers, especially for the informal caregivers. And we have this important socio-demographic data that make a photo of our social network in Veneto region. And you see that about the 76% of our patients live not alone. It's very important. That means that there are a social network. And the social conditions are the bias, the real bias that we have found in this trial. So the caregivers are particularly active, involved, and they have a good advantage like time saving, less concern, improved safety, a lighter commitment. This is the clinical perception. I only have a negative aspect, that is introduction of unpaid workload at the same availability of time. This is a reality because we don't have a mechanism of reimbursement of this activity as in all the parts of Europe. And so this is a problem for the clinician. But this is the evidence. What is the proposal for our policy? Because our decision maker want to have a policy report in order to take the decision. First of all, we have some results. We have from the evidence of clinical evidence, such as number of hospitalization, number of specialistic visits. We have the idea that the service that could permit to access to health facilities only when needed. This is very important. It seems that the patient goes to the hospital, goes to emergency department, goes to the ambulatory visit only when they need the visit. This is not a scheduling approach, but is the on-demand, on-need approach. Another important point is that we have recognized the need of e-health center that filters false alarm. We have about, you see in this part, we have about the 50% of the alarm are false. False means that the patient forget the measure or the patient using the device in not correct way. This is very important because if you connect directly the device at home of the patient to the doctors, to the hospital, you waste a lot of time and you reduce the half the number of the patient that you can treat with this time, with these services for one full-time equivalent. Another point, very important, is that you have to re-engineer the organization for telemonitoring. Because all organization, new technology, means costly organization. One of the problems of this time in which we have provided services and the usual care is to have different pathways. This is very difficult because we have to decide. Or we move completely to the tele-home monitoring organization, or we remain to the usual care organization. Using both organizations for the same type of patient is very a waste of resources. Another important point is to include the health center to give the social support to the patient. All the doctors say that the best result of this trial is to understand the support, the social support that the telecare center gives to the patient. Is very important for them. As you can see, for the perception of the patient, it seems that we have no privacy problem, so we have the privacy policy, the actual privacy policies that are sufficient. Most of the patients are assisted at home, and so we have to involve at the beginning of the services the caregiver in the service management. This is very important. Then, it's very important to focalize on patient empowerment and training since the beginning of telemonitoring services. In our case, we have very few people that are familiar with technology. And so we spend a lot of time to them to learn the right way to use the device and to use the services, because with the device we provide the telephone support, the social support to this patient. Last, but very important for politician, decision maker, not for everyone, that decrease in hospitalization means more availability of beds. And this is very important for political point of view in my region, but I believe that this is a crucial point in every part of the Europe. Thank you very much. I believe that I have the same idea of Panos. It's very difficult moving from a randomized control trial in this type of services, using only this result to make a decision of using or not using, we have to make other type of study with a large scale number of patients in different organizational situations. So we need that we have a cross-border project like United for Health. Thank you very much.
I think we have, because I know in just a few seconds, I think people come flooding in. So maybe we have time for one question if someone's in the audience is dying to ask Claudio something. No? Yes? You have one here? Oh, there's someone, yeah. You can.
I was wondering about the feedback to the patients that were false alarm. How did you, or have you any idea how to handle that situation? Because naturally it will arise concerns within the patient if they got an alarm that says that this has to be dealt with, and then the system says that this is a false alarm.
Yes, we have an agenda of monitoring agenda in which we have how many measures the patient have to perform and different results that has the normal measurements and the abnormal measurements. So every time we have a measurement that is out of range, an operator of the telecare center calls the patient at home and asks to the patient to redo the measurement. If the measure is confirmed, in this case is a true alarm. If the measure is not confirmed, in this case is a false alarm.
And the patient experience, it doesn't arouse any concerns with the patients?
From the patients, it's very nice because also if there is the patient forget the measure, in this case the patient is called from the telecare services. It seems that we analyze the trend of this type of false alarm, and it seems that the false alarm is in the first period of the follow-up. We believe, but we can prove that if the patient is not compliant with, for example, for drug therapy, in the case of congestive heart failure, and the patient knows that he is not compliant because he forgot to take drugs or something else, and there is an alarm, and the telecare center calls the patient, this type of information, this type of calling from e-health telecare center improve the experience of the patient, moving to more compliant style of life of the patient. Okay. But we have no proof of this.
Okay. Okay, thank you so much, Claudio, from the organizers. A little something for you. Thank you. And I think just to wrap this session up, I'd like to thank all of you. It does look like most of you stayed and came back. I appreciate that a lot. Thank you so much to the speakers for making time to do this. Thank you so much for the organizers for letting us have our United for Health session. And thank you so much to ETEL for actually organizing it. And we'd just like to draw your attention to the fact that you can actually read a little bit more about both Renewing Health and United for Health. Downstairs, next to the registration desk, you can find these flyers, but you can also go online since we are talking about technology much here today. So thank you very much and have a good afternoon, and I'll see you later. Thank you.